If you look across the entire landscape of modern medicine to find the single greatest staffing void in the profession, your search will lead you directly to the pediatric cardiac operating room. We are facing a severe, structural deficit in a highly specialized hybrid discipline, pediatric cardiac anesthesiology. These are the specialized physician anesthesiologists who manage the delicate, volatile physiology of infants and children undergoing complex open-heart surgery for congenital heart defects. The bottleneck begins with the training penalty. To enter this elite field, a physician must endure 5 to 6 years of postgraduate training after medical school. This requires a standard 4-year anesthesiology residency, followed by a 1-year pediatric anesthesia fellowship, and topped off with a 2nd-year pediatric cardiac superfellowship. It is a massive timeline of lost opportunity cost, and it has created a critical scarcity of qualified specialists. The data from a landmark National Task Force study published by the Congenital Cardiac Anesthesia Society (CCAS) reveal exactly how fragile this infrastructure has become. When surveyed by the CCAS, division chiefs at major medical institutions across the nation rated the difficulty of hiring new pediatric cardiac anesthesiologists an alarming 8 out of 10. It is not just a recruitment problem, it is a retention crisis. According to the data referenced in the document Pediatric Cardiac Anesthesiology, 31.4% of currently active pediatric cardiac anesthesiologists reported considering leaving the subspecialty entirely. They cite extreme operational stress, high acuity pressure, and a systemic lack of support. We are looking at a system where nearly 1/3 of the existing workforce is on the verge of walking away from the congenital heart room. Furthermore, this void cannot be filled by altering the care team model. While certified registered nurse anesthetists or CRNAs are vital, highly skilled assets in general and adult cardiac specialties, pediatric cardiac anesthesiology is a domain strictly limited to physician anesthesiologists. The sheer physiological complexity of an infant with shunting, complex congenital lesions, and transitional circulation requires the comprehensive, advanced medical diagnostic training that only fellowship-trained physicians possess. Hospital systems cannot simply delegate their way out of this shortage. Solving the absolute greatest void in anesthesia requires a coordinated strategic response from hospital administrators and healthcare leaders. First, institutions must actively mitigate the training penalty by creating robust fellowship pipeline programs, offering targeted financial incentives, and providing aggressive educational debt relief to offset the massive opportunity cost of a second fellowship year. Second, we must directly target the 31.4% burnout rate. Hospital administrators must invest heavily in structural and operational support, optimizing call schedules, providing dedicated administrative time, and building resilient clinical care teams to protect the well-being of these invaluable physicians. Protecting the hearts of our youngest patients begins with building a sustainable, well-supported environment for the elite specialists who keep them beating. If you got value from this video, you may also be interested in our video, The Pain Management Void, which you can access by clicking the video thumbnail above.